Good morning, ladies and gentlemen, and good afternoon to those in the United States. Welcome to the first plenary of the Anesthesia Patient Safety Symposium 2023. And it is my pleasure to introduce our first plenary speaker this morning. And he is Dr. Daniel J. Cole. He will be speaking on the evolution of patient safety in anesthesia, its future direction, and an introduction to the Anesthesia Patient Safety Foundation. Dr. Daniel J. Cole earned his Doctor of Medicine degree from Loma Linda University, where he also completed his residency in anesthesiology. He completed a neuroscience research fellowship at the University of California at San Diego. Dr. Cole currently serves as a Vice Chair for Professional and Business Development for the Department of Anesthesiology and Perioperative Medicine at the University of California, Los Angeles. He previously served as Chair at the Mayo Clinic in Arizona and as Vice Dean for Continuous Professional Development, Mayo Clinic. A neuroanesthesiologist by training, he has published extensively with more than 350 original manuscripts, chapters, abstracts, and editorials to his credit. Over the course of his career, he has served as a reviewer for more than 25 medical journals, and Dr. Cole is also a distinguished lecturer with over 300 invited presentations on a broad range of topics. Currently, Dr. Cole serves as the Executive Director for Professional Affairs for the American Board of Anesthesiology and serves on the Board of Directors of the American Board of Medical Specialties. Dr. Cole is a past president of the American Society of Anesthesiologists and served as president of the Anesthesia Patient Safety Foundation. Without further ado, please welcome Dr. Cole.
Well, thank you, Professor, for that kind introduction. And let me just reiterate what an honor it has been to help plan and participate in this meeting. It's a rich interaction, how we learn from each other. I would point out in this opening slide, and I won't belabor too much, but by giving my email here by the pointer, if there are any questions that come up in the next few days or few weeks, please feel free to contact me. My lecture is by and large US-centric, since we're talking about the Anesthesia Patient Safety Foundation, but there is a lot of common intersection with countries all over the world. I have listed on the side here what I'm going to talk about, and they're a little intermingled, so they're not distinct topics, but I talk about the patient safety movement in the United States, our system of healthcare, and a little bit about trust, our specialty and where our specialty is going, give you some background on the Anesthesia Patient Safety Foundation, and then touch base on some of our patient safety priorities. Let me start off by asking ChatGPT, this new AI expert on everything, basically, when did the patient safety movement begin in the US? And they give you an answer, and I can tell you they're not always right. Here, they're not quite right. But they say it started gaining momentum in the late 1990s and early 2000s. And they cite an Institute of Medicine report, "To err is human." And I'm going to go over that in a subsequent slide coming up here in just a minute or two. If you start off in the modern era, and I'm talking about ether, and you can see here a picture of it was first presented publicly and used publicly in 1846. That's the kind of the modern era of anesthesia. And you can see that there's been a focus on patient safety within our specialty since that modern era. Talked about a patient, Hannah, who died during a chloroform anesthesia. There was a report in the current research in anesthesia and analgesia in 1922 about obstetric anesthesia. And slowly over the next 60 years, anesthesia mortality reports were published from around the world. I will point out also, and you'll hear some more about this in the future, but the American Society of Anesthesiologists that was founded in 1905, and they've had a focus on patient safety from the very beginning. Let me jump ahead a few decades to 1954, when this seminal paper was published in the Annals of Surgery by anesthesiologists Beecher and Todd, a study of the deaths associated with anesthesia and surgery. And here you can see some of the principles that they laid out about our specialty from the beginning. Basically, that it is an adjunct to the care of the patient. It's hardly ever an end to itself, which really highlights our specialty and the importance. It's important in all specialties, but certainly in our specialty, the critical importance and the focus of avoiding making errors. Anesthesia made possible the acts which can accomplish some amazing things. And they stated in their paper the extent of the responsibility which must be borne by anesthesia for failure in the total of the patient. The findings from their studies were even more remarkable at that time. And I think this shone a bright light on patient safety in anesthesia. Surgical patients have a 1 in 75 chance of dying, a 1 in 95 chance of dying from their underlying disease, and there is 1 anesthesia death for every approximately 1,500 patients. Right now, we've arguably would report 1 anesthesia death. It's been reported in the literature from anywhere from 100 to 400,000. So 1 for every 100,000 or 400,000. And at that time, though, they said anesthesia should be viewed as a major public health problem, which again intensified some of our work in our specialty on patient safety. Let me move ahead to the 70s and 80s. And this was a kind of a robust era where there were a lot of innovations and procedures that were being done both surgically and procedurally, a lot of updates and new disruptive technology in monitoring and anesthetic medications, such as end-tidal CO2 monitoring. Pulse oximetry was certainly a groundbreaking movement. We had short-acting anesthetics that came in. And then the training of anesthesiologists, at least in the United States, markedly intensified. We spent a lot of time in the ICU. So that was the background in the 70s and 80s. And in 1985, the Anesthesia Patient Safety Foundation was formed by the founder and president, Dr. G. Pierce, from the Harvard system. I'll talk a little bit more about that in detail later. I'll backtrack just a little bit. When the Anesthesia Patient Safety Foundation was founded in 1982, the public profile of anesthesia safety was markedly raised. This was a primetime news show in American television, and it was called The Deep Sleep. 6,000 patients will die or suffer brain damage. And because of this show, it intensified the public concern on the safety of anesthesia. It also spiked the American Society of Anesthesiology members for actions that would both address some of the malpractice insurance crises that we were having and the public safety. So the ground was very fertile to move forward. But how are we doing today? Again, I'm going to jump forward, then I'll jump back. But this was published last year in JAMA Surgery. A cohort of 1,193 major surgeries were identified in 992 participants. These were elderly patients over 65, and the 1 year mortality in patients who had surgery in this cohort was 13%. So whether that was due to something surgically or perioperatively that was done, or it was a self-selected cohort of patients that were sick, it's a pretty striking figure that 1 in 7 patients died within a year who were elderly. The risk increased with age, frailty, emergency surgery, and dementia. Let me talk about trust, and there certainly is a trust gap in medical institutions in the United States. Over the past few years, trust has plummeted from the 90s when it was at essentially an all-time high in the 70 percentile level to about 34%. And when you think about anesthesia, it is so critically important for us to gain the trust of our patients. Questions that patients have: will I survive the surgery? What will you do to make sure I am safe? And I can't tell you how many patients come in expressing to me they are more worried about the anesthesia and essentially losing control of themselves and not waking up than they are actually about the surgery. Will I wake up during the procedure? Are you going to give me enough? Will I lose my memory, particularly in older patients? And a little bit about that a little bit later. But you can see they come in with a lot of questions that oftentimes they will verbalize. Sometimes they don't verbalize that. And it's up to us in our preoperative visit to kind of allay that concern, make them trust us with their life, and what a precious responsibility that we have to take care of these patients. What do patients want? When you look at a doctor, they want to know that, excuse me, that you are clinically competent, that you have some interpersonal competency, that you can gain rapport with the patient, gain their trust, and that you have the primacy of the patient's interest. You're not beholden to some sort of other financial interest. They have an expectation that the system that they enter is safe, reliable, and meets quality expectations. So let's define patient safety. This is a classical definition of how most people have viewed patient safety, and they view it in the context of medical error, which is defined as the failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. And that's from the Institute of Medicine. But let's look at it from a bigger picture, a more comprehensive picture, which I think is more important to the patients, is more important to our specialty, and more important to how we practice as physicians. Look at it beyond medical error. We're not leaving medical errors, but we want to look at preventable harm, how we deliver care in a way, and it's mainly the system, but they deliver care in a way that prevents harm from the processes of care, the behavior of the humans embedded in the system of care. That's adopted from Dave Gaba and Matt Weinger. I'm going to show you an example of that right here. In the United States, we had a president in 1955, Dwight Eisenhower, who suffered a moderate heart attack. I think he was vacationing in Colorado. At that time, the standard of care was to essentially convalesce, and he spent 6 weeks in a hospital inside an oxygen tank, essentially just tender loving care. The mortality was over 40%. things have changed. 40% mortality is not the quality of care that I would want. But things have changed. Somebody has a heart attack, they may be rushed to have open heart surgery. They may have a stent placed in, or they may have more advanced medical management. But with that system, complexity is introduced into the system. And with the complexity comes an increased risk of error and safety. So overall, the mortality has markedly dropped. I could tell you that I think the system that President Eisenhower had was a safe system. It's hard to kind of fumble or do an oxygen tent wrong. But with the complexity of care for a myocardial infarction today, it's much, much easier. And so the quality has the potential to be sky high, but also we have the potential to have harm, which can kind of put a drag on the quality of that patient. Some quick facts, and it is a tall mountain to climb, and it is still a tall mountain to climb. To err is human is that Institute of Medicine report in which they reported in 1999 that 98,000 people die in hospitals. In the last decade, the methodology certainly can be questioned, but there are several studies that have reported 200 to 250,000 deaths each year in the United States from preventable harm. The World Health Organization has stated that the occurrence of adverse events due to unsafe care is likely one of the 10 leading causes of death and disability in the world. A more recent study just published, I think it was March of this year, was a retrospective cohort study to assess the frequency, preventability, and severity of patient harm in a random sample of admissions from 11 Massachusetts hospitals. And they noted that there was at least one adverse event in about a quarter of admissions. These are not just surgical patients, but admissions in general. About 23% were deemed preventable and 32% were deemed serious. Adverse drug events made up 39% of those adverse events, and surgical procedure events made up about 30% of those adverse events. So you can see that mistakes, harm, and adverse events still occur with frequency in probably a center in Massachusetts that is kind of the epitome of medical care in the United States. And here's my system that the framework of what I'd like to think about it. We're all trying to achieve quality. Does healthcare meet the patient's needs and expectations? It must be safe. It must be effective. It must be patient-centric, timely, efficient, and equitable. But you cannot get to quality without a good foundation of safety. Again, how we deliver care in a way that prevents harm from care. So safety and quality are intertwined, and you just cannot separate them. Safety by itself, as denoted in President Eisenhower, how he was treated for his MI, it does not really give us the pinnacle of care that we want. But the great quality, the great potential that we have, if it is not safe, also does not realize our full potential. And obviously, like I said before, we need system competency and safety, physician, clinical, interpersonal competency, and patient primacy. So let's switch gears to the Anesthesia Patient Safety Foundation, founded in 1985. Here is Dr. Jeet Pierce, the founder and president. I think the lecturer that's immediately following me is Dr. Jeff Cooper here on the side, and a distinguished group of visionaries that founded the Anesthesia Patient Safety Foundation. And note that it preceded most other organized patient safety efforts in the United States. We have a clear and simple vision that no one shall be harmed by anesthesia care. It's an aspiration that we have zero harm, and we know that's a difficult, a tall challenge, but that is our vision. What do we do? Let me just go over some of the things. We've provided over $15 million in research grants. We provide education across the world. We're participating in it right now. One of our premier events, and I will have a slide or two on that in just a minute, is our Stolting Conference, which occurs every September. And we take a patient safety priority or a big issue and have a consensus conference. And a little bit more about that later for you. We have a newsletter. Again, another couple of things on the newsletter in a subsequent slide. But conservatively, that newsletter reaches over 650,000 individuals, and we are read by someone in all countries in the world. We're very collaborative. We realize that the Anesthesia Patient Safety Foundation will not be able to achieve our vision by ourselves, and the extent to which we can collaborate and provide synergies with other organizations is our goal. We have a website, apsf.org. Please go visit it if you ever get a chance. We are very deep into social media. And finally, we do have some advocacy out there. We were highly involved in COVID, particularly COVID recommendations in conjunction with the American Society of Anesthesiologists. We are a foundation of the American Society of Anesthesiologists and work very closely with them to help achieve our goal. We had a statement on medical error. We had a famous case here just a few months ago where a nurse was actually prosecuted criminally for making an error. And then we've given some force in Congress here in the United States to legislation that would help prevent opiate deaths. Here's our newsletter. It's free. It belongs to you. And it is a phenomenal newsletter. You can see our editors, Dr. Steve Greenberg and Dr. Jennifer Benayan. I think Dr. Greenberg is talking a little bit later. Please go to our website if you're interested in it. Again, give us your email and we'll send you the link to our newsletter, which comes out a few times each year. And I would say that it's called a newsletter, but it really has a lot of scholarly advice and scholarly discussion of issues. Our Stolting Conference. So some of the topics that we did in 2021, we did a conference on clinician safety and essentially to care as human and to talk about issues like burnout, which is fairly prevalent here in the United States. Last year, we had a Stolting Conference on non-operating room anesthesia. It's proliferating here in the United States, and there are a lot of safety concerns. We have a manuscript that came out of that conference, which makes recommendations on that conference. It's essentially in press now, and you should see it shortly. This coming year, this coming September 6 and 7 in the United States, we're going to have a conference on emerging medical technologies, and it couldn't be more apropos in the era of artificial intelligence, machine learning, wearable sensors, big data, remote care. And you can envision a future where a patient may come in, may get assessed with some sort of machine learning, artificial intelligence. There may be essentially a guided pathway for that patient specific to their precise medical conditions. They may go home earlier with wearables, essentially physiological wearables that help to define how well that patient is doing. Those wearables may feed data back into a central repository that is monitored, and you may see somebody postoperatively at day 3 that takes a little dip. that would otherwise be not recognized. And you may use predictive analytics to make an intervention in the future. So there's an exciting future there, but we have to do it right. And there's the potential to have adverse effects from this movement forward. So again, September 6 and 7, it is virtual and in person. It is, again, free. And if you're interested in signing up, you can contact our administrator, Stacy Maxwell, there, or just go to our website and you'll learn how to access the meeting. We come up with our priorities and we try and focus our limited resources on these priorities. These priorities, amazingly enough, map very well to priorities in a lot of other countries. And here you can see clinical deterioration, culture of safety, medication safety, teamwork, NORA, infectious diseases, perioperative brain health. I'll talk a little bit about there. I don't say lecture here. Airway management, clinician safety, and then, like I said, emerging technologies. Talking about perioperative hypotension, and this is, I think, my only slide. I know you're going to get a great lecture coming up on perioperative hypotension, but we held a standalone consensus conference in Philadelphia this past November on perioperative hypotension and what to do about it. There's a lot of unanswered questions about perioperative hypotension, and here you can see a figure that essentially shows kind of the sweet spot. Here is kind of looks like a hockey stick or a U shape, where a large cohort of patients does best. So it's been defined that we should try and keep our patients above 65 millimeters of mercury. But who are the patients that are at risk? Here are the answered questions. There are patient factors that make a patient more at risk. What is the threshold for intervention? It's defined as 65 millimeters of mercury in a large cohort of patients. But you know that there's a lot of variability within our patients. And some patients, their definition may be, or their intervention may be at 85 millimeters of mercury. What are the complications I should be worried about? What other information do I need to make an informed decision? Right now, I think a lot of people essentially treat a number. And as long as I can treat that number, get the blood pressure above 65, I'm doing what I'm supposed to do. And that may not be the case in somebody that is hypovolemic, and you just essentially increase their afterload. You may actually be doing them harm. So we have a paper in process that was probably going to be around 4,000, 5,000 words, but very comprehensive recommendations on that consensus conference. Our specialty is moving, and it is changing. When I kind of did my training, we were essentially an induction to immersion specialty, and that's kind of where we needed to be because there were a lot of airway issues. The death rate was around 1 in 5 to 1 in 10,000, and we've dramatically improved that death rate. So our specialty has improved to essentially focusing more on the episode of care and the health span, as I'll say. So instead of just focusing on living, we're not leaving living, but we're also doing some things within our care preoperatively, postoperatively to improve functional health, cognitive health, and psychological health. When I was president of the American Society of Anesthesiologists, we had a focused review of preventable harm. And here are some of the things that we thought about doing interventionally. And we settled on a brain health initiative. And we've had a very robust system of brain health to improve the brain health of patients. And we focused on postoperative delirium, which is an acute fluctuation in consciousness, attention, and cognition. In the United States, this incidence is anywhere from 15 to 60% in the geriatric population. a lot of complications. It costs, been appraised in 2011 dollars at over $150 billion a year, and 40% of the cases are deemed preventable. I also note that there's some prevalence of delirium in Malaysia. A 2019 study reported that 27% of older medical inpatients prevented with delirium. Here's a study in 2021, smaller, about 447 elective cases, and the incidence was 11.2%. So again, there's a lot of commonality in what we do, and I'm going to give you at least what my integrated pathway is for patients that are at risk of postoperative delirium. There's something called the American Geriatric Society Beers criteria, a list of potentially inappropriate medications that are not absolutely contraindication, but you try and avoid them if you can. And you can see that here, benzodiazepines jump out at the top. A lot of these we use. There may be a strong indication for it, but probably try and avoid them if you can. Preoperatively, we try and assess our patients with exams such as the mini-cog, frailty score, and in the future, there's products coming out on artificial intelligence. We have prehabilitation, and if you have a geriatrician at your institution, get them involved. Intraoperatively, some of the things that have been associated with postoperative delirium include the depth of anesthesia, hypotension, not much on anesthetics. In fact, surprisingly, regional anesthesia has not proven to be better than general anesthesia. The one that's a little controversial, there's some recent literature that shows incorporating dexmedetomidine into the anesthetic might decrease the incidence. Postoperatively, very important, get the family involved. It's a way that patients can reorient themselves, treat pain aggressively. Sleep hygiene is one of the best things to prevent delirium. If they get fragmented sleep or no sleep, patients have an increased risk of delirium. Physical activity, if possible, do hearing aids and eyeglasses, and then if you can, get them home as quickly as possible into familiar surroundings. And I think this is my next to last slide, and prehabilitation is essentially focused on building cognitive reserve. And here you can see you have what is commonly referred to as non-modifiable risk, your genes, your biology, we all age, which increases risk. And then you have modifiable risk factors that you can intervene on: healthy behaviors, executive function, social, environmental, and economic conditions. If I were picking out 8 things for a prehabilitation pathway, here are some of the things that I would consider. Exercise is phenomenally effective. Good sleep hygiene, a diet such as the Mediterranean or the MIND diet, weight loss, smoking, treating hypertension and diabetes, and getting rid of some of those medications that are on the Beers list. What is not known is that these are good, healthy lifestyles in the long term, but how long do you have to do that prehabilitation to make it effective in a patient perioperatively? So again, good, healthy lifestyles, changes that the patient can make anyway. And so encouraging these, I think, will certainly give them a better quality of life and maybe improve their incidence of delirium. In closing, I showed his previous analogy of a tall mountain, but consider it a marathon. Quality healthcare cannot be achieved without robust systems of safety, and I think patients have a right to healthcare that is safe, reliable, and free from harm. And it is a marathon. We never stop running forward, moving forward. A quote paraphrased here from, again, the founder of APSF, G. Pierce: patient safety is not bad. It is not an objective that has been fulfilled. It is an ongoing necessity. It must be sustained by research, training, and daily application in the workplace. And I thank you for your attention. We'll try and navigate my way back to the screen where we can answer questions.
Thank you very much, Dr. Cole, for that very clear and comprehensive lecture on the evolution of patient safety in anesthesia. Uh, Maybe I can start the ball rolling by asking you the first question. It's interesting that you have started your lecture with a slide on Chat GPT or artificial intelligence. Um, can you tell us about what do you think the impact will be in the impact of AI on patient safety? Is it all good, or are there any bad side effects as well?
A great question. I think AI has the potential to be a positive disruptor in healthcare, much the same way as ether was back in 1846. But if it's not done right, again, you start to think about extrapolating decisions across hundreds of thousands of patients. If it's not done right, it could actually produce some harm. And so we need to go deliberately and cautiously as we start to incorporate some of this disruptive technology. And that basically was the reason for our Stolting conference this year in 2023, is that we want to get experts together to deliberately consider how we take the next steps in incorporating this.
Um, I can't help but notice that you are a neuroanesthesiologist, and you have held many big posts uh, in many institutions pertaining to patient safety. And it looks like they love anesthesiologists as leader for patient safety. Why do you think that that's the reason? Uh, is there any particular reason why anesthesiologists are preferred to be leaders in patient safety?
Well, I think across the whole healthcare spectrum, we have a legacy here in the United States of being first on the block. The Anesthesia Patient Safety Foundation was way ahead of its time. There was something called the National Patient Safety Foundation that was formed about a decade after we were formed, and they patterned themselves after the Anesthesia Patient Safety Foundation. And again, we have this background where patients don't come in to hospitals to get anesthesia. They come in to get surgery or a procedure. And so there is absolutely no room for error. And so we as a specialty have been laser focused on patient safety. And we've been that way in our home institutions. And then we've made some remarkable improvements in patient safety, as evidenced by the change in mortality from anesthesia over the past 3 or 4 decades, from around 1 in 5 to 10,000 to around 1 every 100 to 400,000. And the next frontier is to start to work on these things like preventable harm, myocardial injury after non-cardiac surgery, acute renal failure after surgery, sepsis, the brain health initiative that anesthesiologists as advanced. So again, we have this legacy, and we're not stopping. And so again, people look to us as that natural leader of patient safety.
Thank you, Dr. Cole. Regarding the foundation, Patient Safety Foundation, who are the members of this foundation, and uh, can anyone be members, and how do we apply to be members?
Well, it's not a membership organization. Essentially, we're a foundation of the American Society of Anesthesiologists, and we have a board that includes 18 people, and that includes anesthesiologists, nurse anesthetists, anesthesiology assistants, equipment manufacturers, people in industry, attorneys, malpractice type attorneys, etc. where we all get together in a safe environment and decide on the issues. You can certainly not apply, but express your interest in being engaged in the Anesthesia Patient Safety Foundation. And we're growing that. It would be a couple of different avenues that come to mind. One would be contributing to our newsletter, which again, we're trying to do internationally. The other one would be to becoming involved in some of our patient safety priorities. And you can see we had 10 priority groups, and we have pretty big groups that are involved and engaging in those priorities. So people are welcome to express their interest, and we'll try and find some activity for them to do. But there is no cost to becoming engaged. It's a passion for everybody.
Uh, we have 5 minutes more. Um, um, Maybe since there's no more question, maybe my last question from me is, um, what would you think is the most important milestone in the evolution of the anesthesia patient safety?
Uh, well, it was the foresight of the amazing pioneers back in 1985, 86 to actually form a foundation and to solicit funds and resources so that we could structurally start to attack some of the issues within our specialty. So actually forming the foundation was probably the most important milestone. But again, sustaining that over the past 40 years has just been amazing.
I agree. Uh, okay, since there's no more question, I would like to thank Dr. Cole again for that very enlightening and interesting talk, and I would like to uh, uh, invite the organizer to take over to take us over to the next session. Thank you very much.
And thank you again.
Thank you.